Just text me when you get close. I'll run down. That's okay. What? It should be. Oh, okay. Okay. I mean, that'll work. I'll just go make sure it's out there. I'm What?
That's great. Hey everybody, can you guys hear me? Yes, yay, great. All right guys, we're gonna get started. We do have 2 cases and a didactic today, so it's a nice full session. We are gonna start with introductions. I'm thrilled, we have a lot of people. All right, so let's see. Jennifer Boyd, will you start with introductions?
I will. I'm Jennifer Boyd. I'm a physician assistant at New River Health Center, working today out of my Fayetteville office.
Perfect. Thank you so much. All right. Let's see. And Dr. Tierney?
Hi, Dr. Tierney from Cabin Creek Health Systems, and I have 2 fourth-year medical students from WVU with me, Victoria and Madonna.
Hello. Awesome. Welcome, you guys. All right. Let's see. Williamson Health and Wellness. You guys want to introduce yourselves?
Hi, I'm Tracy Thornsberry. Oh, we're having internet problems. Jerome, you need to turn your other computer off.
Sorry.
That sounds Halloween-y.
Yeah, it does.
Feels Halloween.
Okay, is that better?
Yeah.
And we have had internet issues all morning, so we're just scrambling to get on. So we're happy to be here. This is our first echo with you guys. We are familiar with a little bit with the project. We do it with Marshall currently. So we're happy to be here. I'm Tracy Thornsberry. I'm a nurse practitioner. I have
Deborah Epling, nurse practitioner.
And Jerome Klein, nurse practitioner.
Marvelous.
Yay.
Thank you all. We're happy to have you.
Yeah, thank you.
All right. Let's see. Dr. Rushton.
Yeah, Dr. Rushton from Logan Mingo Area Mental Health. I'm here mostly to update myself on hepatitis treatment.
Wonderful. Thank you so much. All right, Matt Weimer.
Hello, can you hear me?
Yeah.
Hi, I'm Matt Weimer. I'm a family doc at Valley Health Systems. Happy to be with you all today.
Wonderful. We're happy to have you. All right, Greg.
Hey, I'm Greg Peters. I'm a family medicine doctor from Buchanan, West Virginia. I work with Community Care of West Virginia.
Perfect. Thank you. And Jenna?
Hi, I'm Jenna Ward. I'm a physician assistant. I work with Community Care West Virginia in our Rock Cave office.
Wonderful. Thank you so much. Let's see. And Sue McKenrick?
Hi. I'm a nurse practitioner. I teach at WVU in the nursing department, and I'm owning a hepatitis.
All right, great. Thank you. All right, and then Carmen?
I'm Carmen Rexroyd, family physician at Pendleton Community Care in Franklin, West Virginia.
Excellent. Thank you so much. So here, I'm Caitlin Ettinger, Project ECHO Coordinator.
Carolyn Kidd, Clinical Nurse Educator, Mid-Atlantic AIDS Education Training Center. Hi, Greg.
Hi. I'm Kaylee Berner. I'm a nurse practitioner with infectious disease here at WVU Medicine.
And I'm Rachel Mitchell. I'm a pharmacist in the specialty pharmacy here at WVU Medicine.
Excellent. All right. Jen, do you care if we start with your case?
That would be fun.
Perfect.
I should explain that this case is going to be slightly weird because some of her labs didn't get completed. Specifically, this lady's FibroSure didn't come completed, and I don't have results of an ultrasound yet. And so I don't know her fibrosis score, but I'll tell you her story, and then I mean, we could talk about treatment. She's not actually quite ready for that, but assuming, that her fibrosis score is low, then it might be useful to just talk about what appropriate treatment would be. So she is a 28-year-old Caucasian female. She is slim with a BMI there of 19.6. She has Medicaid insurance. Her suspected route of transmission of her hepatitis C is most likely IV drug use, although she does have several non-professional tattoos. She started using injection drugs at age 22. She's used heroin and meth. She was, as you can see from my notes, she was in rehab 3 years ago. And when the day I saw her, it's the first time I've ever met her, I'm not quite sure how she was referred to me. It might have been by our health department. When we first were talking, she said she hadn't used in 10 months. Then when I started talking to her about the Medicaid requirements for treatment, she acknowledged that she had used recently. She didn't say how recently, but she was getting into counseling, and she was thinking about MAT for her substance use disorder. She gets Suboxone on the street to curb cravings and finds that helpful. I encouraged her to get into our program. She says that she currently uses clean needles and doesn't share. I don't know how much she clearly was didn't know me and wasn't comfortable being quite forthcoming with me. So I'm not sure how much of her story she's really being truthful about. But I felt like we developed some rapport during the visit. So that was good. She says she was diagnosed in 2016, and then that she was told in 2018 that she had cleared the virus, and then got tested recently and was positive. I am thinking I didn't send for any of her old records. That might be something that I should try to do. She's been vaccinated for both Hep A and B, she says. I don't have those records, and that was part of the blood work that didn't get done that day by our lab for some reason. I put in orders and contacted her to come back for the lab work that wasn't done. Some of it was, some of it wasn't. It was the in-house labs were done. The labs we sent to LabCorp never got done. She does have depression. She is followed by one of my colleagues here and is on Remeron and finds that helpful. She is, she's currently using alcohol. I don't remember that story. And I could go back and look in my notes. I, of course, asked her to stop, and we talked about, trying to get her into treatment for her opioid use disorder. She is a smoker. So the labs that did get done in-house, you can see here her CBC was normal, her renal function is normal, glucose, PTINR. Her albumin was slightly elevated. Her ALT was very minusculely elevated. Their other LFTs were normal. Total protein slightly up. Her iron studies were good. Her vitamin D was 32, which is just within the range of normal for our lab. She's HIV negative. Her viral load, her hepatitis C viral load did get done by the outside lab. It was 1.3 million. And her genotype is 1A. So we did, I don't know why that's interesting. I put a fibrosis stage on here. I have to check that. I'm not sure where that came from because I got it. And that might have been an old fibrosure. In a minute, I'll just go check on that. Because I definitely, the day she saw me, the blood work did not get done. So let's see if there's anything new in my notes. I was a little worried about her being able to stop using. She's living with her mom. She had not yet disclosed to her mom that she's still using. And when I gave her a prescription for Narcan, and she said, I'll have to tell my mom why I have that. It was pretty poignant. Her sex partners are female, so she's not at risk for pregnancy. Her ultrasound was scheduled for this week. The day I called to tell her that her labs weren't drawn, she had had all her teeth pulled. And her mom said she would get the message to her and that she was scheduled for the ultrasound. So that was her story. This is a person who sorry, I'm just looking at my labs. I have conflicting results up here. I'm going to go back into her chart because at one point I say 1.3 million and at another point I say 3.8. I think she was 3.8 million and that I don't have a fibrosis score, but I'll double check that. She's somebody I feel is likely to not return or to get lost, although she has kept follow-up with her, my colleague here who treats her for depression. So to keep her, engaged, I'll have to work hard, I think. But we did, like I said, establish a rapport, so I'm hopeful maybe that can help her stay engaged, get treatment for her opioid use disorder, and then get treated for her hepatitis C. That's the story, but guys, let me clear up this craziness about the results. Here is one from 10/8 that says they did not process her fibrosure. Her viral load was 3.8 million and her genotype was 1A. Now, let me just go back and see. I don't know why I put that in there about the fibrosis score because I don't have that. So I understand that makes it a little bit tricky to talk about treatment, but assuming that her fibrosis score, I thought we could just talk about options if she doesn't have a high fibrosis score. Hi, Dr. Feinberg. In text land. That's okay.
You guys have any insights, thoughts, questions? Bye.
Hey, Jennifer, it's Greg. I wrote down a couple of things. I thought it's interesting if that's true that she's really buying, not sharing, not reusing, clean needles. It sounds like maybe she has some insight into harm reduction, which is awfully encouraging and reassuring. If that's the case, you might talk with her about PrEP, just because she's somebody that is at risk, obviously, if she's in active addiction. I think what you described, I mean, her fibrosis score, I think, is unlikely to be very high. Her vitamin D, I think 40 is kind of the magic number. A genotype of 1A, you could treat with almost anything when she's at some point ready. I think you're right, she is. And there was one other comment I had. It's just something that I try to keep in mind. You mentioned about birth control in her. You might actually revisit that with her at some point, because even patients sometimes whose preferred sexual partners are female and thus the risk of developing pregnancy to near zero. if they're in active addiction, sometimes they trade sex for drugs, even with people that are not their preferred, sexual partners. In fact, usually with people that are not their preferred sexual partners, which does actually increase, obviously, the risk of all sorts of different things, including HIV, which is where, PrEP might be a good thought in her, but also, if to avoid pregnancy, I think is wise, particularly in somebody that in that phase of addiction. So I think you're going to take real good care of her. I think you're going to do really well.
Well, thank you. Those are helpful suggestions. And so the vitamin D, could that just be oral, or should that be? Should that be low dose, or should that be high dose?
I don't think, at least in my experience, I don't think there's any wrong way to do it necessarily. I tend to use pulse therapy, that 50,000 international unit dose once a week, just because that seems to be easy for people. It's very hard to hurt yourself with vitamin D, I find. So, but yeah, I give them 50,000 units, and I give them 12 pills, and that's probably enough. And sometimes I'll repeat it, and then it's low again. And sometimes I'll just keep them on. I'll just keep them on it and check it occasionally. I've never had somebody come back with super therapeutic levels of vitamin D. I never see that, particularly people that are using drugs or smoke or live in West Virginia. It just doesn't seem like I see people with really high vitamin D levels ever.
Thank you.
Jennifer, it's Carolyn, AIDS Education Training Center. Hi. So she's in your service area. Does she have access to a syringe services program?
Yeah, we have a wonderful harm reduction program at the health department here in Fayette County. I think that's how she got referred to me.
Oh, she might have, because I know, just kind of following up on what you said about her history of purchasing syringes, I wonder if she actually goes to that syringe services program.
I will make sure. I think that she does. But of course I'll make sure.
Yeah.
Because we talked a lot about, although I didn't offer her PrEP, that's a good point, but we talked a lot otherwise about harm reduction.
That's awesome. Y'all are doing great work.
I feel so to live in Fayette County and have this health department here. They're just amazing, doing amazing things in our county.
That's awesome.
Susanna Massardis.
Hey, glad you could join.
Sorry, I'm a little late. I was on the New Jersey elimination call. It's elimination day.
Great. No worries. Happy to do it.
Sure.
All right, guys. Kaylee,
Yeah. Jen, great presentation. It gives us a lot of opportunity to talk about harm reduction. She's a great case, even though if she's not quite ready for Hep C treatment yet. Great job giving her Narcan. The couple things I wanted to point out, when you were talking about kind of when she first established with you and said she really hadn't used in the past 10 months, sometimes I notice, patients, if you ask, when's the last time you used, or however you plan on phrasing it, I mean, a lot of times they may reference, oh, not recently as far as their injection, but really they've been snorting, smoking, ingesting in other forms. So, it's always a good idea to kind of specify the route of administration, because sometimes they don't really think, oh, I'm not injecting anymore, so I'm not using. But then when you bring it up as far as, hey, as far as treatment goes, you need to be drug-free for X amount of time. They're like, oh yeah, but by the way, I've been still snorting cocaine or whatnot. So just that brought up a good point. I'm glad that you brought that to our attention. And then a couple other things. When you were talking about her diagnosis was in 2016, and then told she cleared and had a positive test in 2018. So a couple scenarios, particularly for some of the newer spoke members that have joined us today, couple scenarios that could have happened. I mean, being that she's been in active addiction, I mean, she certainly could have been exposed to hepatitis C in the past and spontaneously cleared. We tend to see our younger female patients that are fortunate in that regard, that do spontaneously clear. this virus and then gotten reinfected again. The other scenario is there's really been some data that's suggested, you know, you can have these transient periods of undetectable viremia even with chronic infection. And so really, if you're trying to determine if somebody's been recently exposed versus chronic infection versus been spontaneously cleared and then reinfected with Hep C, really trying to trend their viral load and having 2 negative viral loads obtained 6 months apart. If they're both not detected, then you can be more confident that they actually have cleared the virus. In her case, and a lot of times, unfortunately, you know, our patients don't stay in care long enough or consistently enough that we're able to obtain them in that manner. But those are just a couple different scenarios to think about as far as her case, and also to discuss with her as far as, you know, you can get reinfected as many times as you get exposed. So if you happen to clear this again, it's not meaning that you're protected from getting a new infection. And so I think it's a really good point to make as far as continuing to build rapport with this patient is, you know, really focusing a lot of your efforts, as you have been, on harm reduction and kind of openly discussing her use and if she's sharing works and how to reduce different transmission risks, and kind of helping build her knowledge base and her insight while establishing rapport with her and hopefully kind of guiding her in a direction that's going to be beneficial to her health and hopefully get her Hep C treated in the future. But a lot of times, you know, those are just the first steps, is getting her to trust you enough that she wants to come back. And even if she may not be as engaged as we'd like her to be, you know, it's still showing, if she's showing up and she's asking questions and she is using the syringe exchange, that she is, you know, caring about her health. And I think the only other comment that I have as far as her case, because Greg brought up a great point about PrEP. I don't know if you guys have seen that Descovy was recently approved, the tenofovir alafenamide for PrEP. However, that data has really been studied with MSM. So the Descovy hasn't really been approved for females, for heterosexual contacts yet, just because of lack of research. So Truvada is still the preferred agent for PrEP in females.
Okay.
Okay.
Good.
But thank you, great case. A lot of teaching points there.
I just have one question, and that is, I am forgetting the significance of the vitamin D physiologically. Could you talk a little bit about that, Kaylee? Like, why is it important for her to have a normal vitamin D level?
So typically, you know, in certain conditions, as far as liver health, we like to keep their vitamin D levels around 40 or 50. You know, and Greg was correct in saying, you know, I mean, you could either do the high dose once a week, 50,000 units. If she wants to take a daily pill, she could do 1,000 to 2,000 units a day. She's not particularly low, but just to give her a little bit of a boost.
Right.
Great.
The issue here, Jen, is that you need good vitamin D levels for your immune system to operate optimally, right? And for viruses like bacteria and any other infectious disease, it's not just the antimicrobial that does the job, it's the antimicrobial and the person's immune system. We really want her immune system to be as tuned up as possible. And this is true in a number of other, you know, disease states. And in some, you know, they look for, like an MS, they look for a vitamin D level above 70.
Oh, wow.
And
Yeah.
that's an autoimmune thing. But, you know, so I would say, you know, in hepatitis C patients, I would always aim for at least 50.
Okay, great.
It's already at a pretty.
I have a related question, if I could. It's more on the getting the lab paid for side. So does having hepatitis C cover a vitamin D level? Would that get rejected, or maybe long-term use of medication as a code? Like, I know we get a lot of feedback from our compliance people at Valley about rejected vitamin Ds. And so I'm just thinking about what diagnosis we use to get that in somebody who's otherwise pretty healthy.
I've only ever used hepatitis C and never had it rejected, and most of mine are,
Okay, cool.
are Medicaid. So I
Yeah,
think that's
I've never had one kick back either, and it's for hepatitis. I just put chronic hepatitis C or viral hepatitis C or whatever the one if I don't know that it's chronic, but I've never had one kick back.
Good deal. Thank you.
Thyroid is the other thing. So like a TSH, right? So like that's one of the banes of the existence of family medicine doctors, is trying to get a TSH paid for, and that's something else that you would test in somebody that has hepatitis C. And I've only ever used hepatitis C as that diagnosis code as well.
Great. All good questions.
Thanks, you guys. And I looked at my notes, Caroline, and I did refer to our local harm reduction program that day.
Awesome.
Best.
Awesome.
Great work.
All right, Matt, are you ready to do your case?
I am ready. Thank you. So this case is a little bit more straightforward, I think. This is a 41-year-old. He came to me in 2012, and he was coming in because of some like anxiety, OCD type behaviors. He was already in a Suboxone program at that time, and I left that out of the history here, so I apologize. He disappeared for about 4 or 5 years, came back. At that time, I think he'd already been diagnosed with hepatitis C. I did the labs. He was genotype 2B. He was viral load of 1.7 million at that time in 2017. I referred him to a GI doctor in town, and he didn't go, and then he disappeared for about 2 years. He came back to see me in, I think, August of this year, kind of for ongoing stuff with depression and anxiety. As you can see, he's on an SNRI and trazodone as well as buspirone. He gets the trazodone and Suboxone from a psychiatrist. He's on Suboxone 1 to 1 1/4 strips a day. And then he gets the duloxetine and the buspirone from me. But anyway, he came back for anxiety and depression. We checked his hep C labs again, and he told me that he didn't go to the GI doctor previously 2 years before because he just was kind of anxious about seeing a specialist and a stranger of sorts. And so we kind of talked about this, and he said, let's do this. So his mode of transmission was through IV drug use, which he last used he knows the exact date. It's December 12th, 2011. He was arrested and incarcerated for maybe like less than a year. That was his last use. His only real substance use at this point is occasional alcohol. He is, again, he remains in a Suboxone program. He's been in a monogamous relationship with a female partner since 2012, I believe. And I think they have children. So it's a fairly stable social situation at this point. And so if we could go back up a little bit, he's a little bit overweight, but otherwise pretty healthy. He has hidradenitis suppurativa that's been, as you all know, difficult to manage. And that's pretty much it, other than the behavioral health, mental health stuff that I talked about. He has not been fully vaccinated against Hep A and B, but he's had the first of both. His depression and anxiety when I saw him in September were not well controlled at that time. Despite being on medication, his PHQ-9, as you can see, was 20, so pretty severe still at that point. And the anxiety, I don't have in here, but it was similar. I think it was like 20 out of 21 or something on the GAD-7. If you go down to his labs, everything looked pretty good, although I didn't do a vitamin D. And the most recent TSH I have on him is from 2017, but it was normal. His LFTs have always been normal. And his most recent Hep C viral load was 5.9 million. So he's never been treated before. And I have the two tests about 2 years apart showing that increase from 1.7 to 5.9. That's about all I have for you. I am trying to get an ultrasound of his liver. I suspect that'll probably be normal, but we'll see. I want to look for kind of some fatty liver too. He's overweight, but his LFTs have been okay, as I said. And his fibrosis score is F0, 0.03. And that was just done last month, I believe. So that's him in a nutshell. He is ready for treatment. I think he'll commit to treatment. And I was thinking, this is my first one, but from the research I've done, I thought maybe Maverick for 8 weeks would be appropriate for him. But I don't really know much more beyond that.
That was awesome. Thank you so much, Matt. Yeah, I'm going to ask you guys out there what your thoughts are.
Questions?
No?
Matt, you're the man. I think you're going to get to treat that guy. It's going to be pretty fun. Like
I'm looking forward to it. I've only treated one other person. I got it through patient assistance. The guy's uninsured. That was a couple of years ago. And so this will be good to be able to finally do this.
I think Epclusa is the other one that you could consider in him, but Mavreet's easy. I think that's probably true. Just one thing to think about too. You mentioned that he's in a monogamous relationship. She should be, if she's a patient, even if she's not a patient of yours, you ought to recommend that she get tested. And then their kids actually ought to get tested too. If they're, I think it's 18 months of age. I'm pretty sure it's like they have to be at least 18 months of age, or we wait until they're 18 months of age and you check that. It might be 12 though. I'm sure.
I've seen 15 to 18 for.
Yeah, so you might screen them if they're older, like if they're 4 or 5 years old or whatever. I test them. They've got a first degree household contact that has hepatitis C. If they've never been tested, it's a good reason just to go ahead and do that anyway. So
yeah, good thought. Thank you. So I had a question about monitoring him once I start treatment. I know we look for the sustained response after treatment, and I read that I should be doing like maybe a CBC and maybe a comprehensive metabolic panel 4 weeks into treatment. Is that pretty much all I need to do? He's Hep B negative, by the way, I didn't say that, and he's HIV negative.
All right. So, hey, Matt.
Hey.
So let me share some thoughts about this guy. Boy, he's really going to benefit from that getting rid of the fibrosis restriction.
Yep.
And he's way more than 3 months abstinent. I would certainly, given how high his PHQ score is, despite multiple medications, if most of those medications are being, I think 2 out of 3 are being managed by the psychiatrist that treats his opioid use disorder, probably worth a reevaluation. Actually, I think it's quite amazing that he feels so bad and hasn't used again. That speaks highly for his determination, I guess, to avoid relapse. But you would be concerned about that, and plus it's probably not comfortable to live with that degree of depression and anxiety. So I would send him back to his psychiatrist. You definitely need to know his vitamin D level and replete him as is necessary. The other thing I think about medically is that, especially given that he's, his BMI is a little elevated, I would for sure get a lipid panel on this guy, and then also see what your ultrasound shows you, because they are concomitant fat in the liver.
Yeah.
And hepatitis C, it exacerbates your situation. And actually the fatty liver disease has now supplanted hepatitis C as the primary reason for liver transplant. So it'd be a pity to cure him of his hep C and then have his liver go south on you because, he's got some fatty liver disease. So, and it sounds like he's a guy who accepts guidance, and, if he's got some fat in his liver on ultrasound and you don't like the look of his lipids, he might do fine with some modest weight loss. May not need to take a statin if he can just, I always like the pathway of less medicine rather than more. But it sounds like he is very approachable as a patient. So I would see if you could get him to lose a little weight. That might, take care of that entirely. I will tell you that I am not, I guess you could do, look at metabolic stuff like a month into treatment. That's not unreasonable. Test of cure and SVR is 12 weeks after the completion of treatment. But sometimes people are not good about returning at that delay when treatment ends. So, and he's had a history of sort of disappearing on you before. So you might think about getting a viral load at the completion of treatment.
Okay.
And tell him, you know, come back 12 weeks after that. Because if he doesn't come back 12 weeks after that, then you're kind of left in that fuzzy area, right, Kaylee, of kind of not really knowing, did he not respond to treatment? Did he somehow get reinfected? You know, what is his story? So I am more and more tending to try to nab people, especially people whose source of acquisition was of Hep C was drug use, trying to get them as they complete therapy. I know that's not guidelines, but it turns out to be incredibly useful. Don't you think, Kaylee? I mean, just this is, and I think you will have, it'll be so satisfying to cure this guy. Oh my God.
Yep.
You're really lucky he's been in recovery this long. He should sail through it.
Yeah.
You know, and you will reap the reward of having cured someone, which is just a fantastic feeling.
Yep.
And it sounds like his life is on track, and his likelihood of getting, you know, reinfected and relapsing. I mean, he's been in solid recovery now for 8 years. So I would just say a few encouraging words to him about that, because there's no magic amount of time in recovery that precludes relapse down the road. But, you know, once you're cured, you're not likely to get treated again in West Virginia, and he's got Medicaid. So, right, I'm not sure Medicaid will go that far.
Yes.
We really want him to cure and stay cured.
Okay. Yep. Thank you.
You're welcome.
One question, just to clarify, back to the vitamin D. Is it really important to get it to 40 before you start treatment? Or?
No, but,
Okay.
you want to get it up there.
Okay.
And, you know, depending on where he is, you know, if he's in the mid-high 30s, he can probably just do 2,000 units a day.
Yeah. Yeah.
But if he's lower than that, then I would, you know, I would take the Greg Peters approach.
Weekly. Yeah.
Giving him a weekly high dose and then reverting. Because you do want to get it up there. I mean, it's not necessary to achieve that prior to treatment.
Okay, great. Thank you.
Is there any scientific basis to think that that might also improve his depression, or is that just folklore from the lay press?
I'm not aware of any solid data that having a hefty vitamin D level improves your mood.
You know what's interesting? This is a tangent, but in elderly patients, taking vitamin D seems to reduce fall risk, and I don't know why. Not just fracture risk, but actual fall risk.
Yeah.
I'm not sure what that's all about. Totally an aside, but it's, I think, worth noting.
Right. Well, you know, the issue is that there are so many associations in literature. But cause and effect are another story altogether. So I have no idea. I worry about my falls too, and believe me, I take my vitamin D every day, but I have no idea why that is the case.
Yeah.
You know.
Before we go to didactic, I just want to say once again, thank you to everybody on ECHO, because these two cases today really speak to me to the power of the personal relationships that people have or can establish with their primary care provider, and to be able to move the treatment into the sphere of primary care with support from you all at the hub. It's just really gratifying.
Yeah.
Right on. That's the truth. Thanks for saying that, Jen.
Right. Thank you.
You know, Matt, like to that point too, like you may very well find that after you treat this guy, I wouldn't be the least bit surprised if this guy would lie down in traffic for you if you asked him to. Like some of these people are just unbelievably grateful after you treat their hepatitis C, and you'd be, or at least I have been, amazed at how much more compliant they are in all other facets, but much more engaged in things like diabetes management, weight loss, you know, getting rid of high fructose corn. We're working on their NASH. I mean, just like that sort of stuff. I mean, it's really, you can really do a lot for people. Not to mention the fact that irrespective of vitamin D, when you treat people's hepatitis C, I'm convinced it makes their depression better. I think they just do better overall. And it's just really, but it's good for you, man. It's awesome.
Oh, thanks. Good points.
depression is really part of the CNS spectrum of hepatitis C, and people's mood does really improve. I don't know if it'll make him go from 20 to 0 without other intervention, but you are likely to see an improvement. And I want to just say, and follow up to Jen and Matt's comments, when you think about being a primary care provider for adults, there's damn little that you can cure, right? Everything is long-term management. There's very little in this life that you can make just go away. And it is so wonderful. It is such a great feeling to make a problem disappear from the problem list. That yeah, you will love it, Matt. You will feel really good about it.
Well, I appreciate the chance to do this and to help this guy out. I look forward to finding some more.
Well, ask him if he's got friends who have a problem.
Yeah. One more comment before we move on to the didactic?
Hey, Matt, this is Kaylee. I just wanted to make a few comments about treatment options, just because you do the two treatment options for you are Mavorite for 8 weeks. And this is a 3-tablet formulation taken once a day. It needs to be taken with food. The other one is the Epclusa for 12 weeks. It's just 1 tab once a day, and it can be taken independent of food. So when you have kind of 2 treatment options, they're both covered by his insurance, without any preference. But I kind of give the patient the option, what's going to work best with their lifestyle. Do they eat regularly enough that they're going to be able to take the same time every day with food? Or is it more something that they wouldn't mind taking 3 months, but only having to take 1 pill and not having to worry about the food intake? But either one is absolutely a great option. Typically, I'll bring them in for a 1-month treatment follow-up, and at that visit, get a BUN creatinine, hepatic panel, and their hep C viral load. And then as long as if the viral load's already undetectable at that time, just depending on how closely you want to follow them, how well you feel about their compliance. I mean, you may opt to not see him until after he's done with treatment. I kind of tell patients the 1-month visit is like a sneak peek that everything's working. And honestly, with genotype 2, the efficacy rates are like 100%. So, I mean, really failure happens if they're not compliant. But I would just kind of let him know that really you won't know if he's cured until 12 weeks after he's finished. So it's super important for him to make sure he comes in for follow-up so that you can ensure everything worked in regards to his treatment. And Medicaid and their MCOs also kind of require that 12-week SVR data, or else they won't consider treating them again. So you may want to kind of let him know that too. And then just because this is one of the first that you've treated, I just want to remind you about the consent forms. I'm not sure if you're aware of those through Medicaid, but it's something that you and him will both need to sign, and we can always send that out in an email too, just so that everybody can print off and have. And that's Medicare, West Virginia Medicare, Medicaid specific, right?
Let me mention one other thing, because Dr. Tierney and I have spent a lot of time and effort trying to convince Medicaid to do the right thing. What they have told us is they are very unhappy that they do not get that SVR data. And it's very important, given the cost of these medications and the fact that they've now gotten rid of the fibrosis score, for them to be able to say, well, yeah, we gave this medicine out, but we cured, 98% of the people we gave it to, or whatever. So just for everybody on, on the webinar today, do not forget to submit that data to Medicaid, because that is crucial to our continuing to get the cooperation we've gotten out of them. I see Dr. Tierney shaking her head. You want to say something, Letitia?
And don't forget to vaccinate. I did want to address one other question you had, Matt. I pulled up the guidelines because I wanted to make sure I told you correctly. It is recommended per the guidelines that after 4 weeks, you get a CBC, a creatinine level, a GFR, and hepatic function. and a thyroid every 12 weeks if they're getting interferon. Okay, and that you can get a more frequent assessment if you're worried about drug-related toxic effects. But that's the recommendation in the guideline, because they say if you see a 10-fold increase in the ALT at 4 weeks, you should discontinue therapy. And an increase of less than 10-fold at week 4, but accompanied by weakness, nausea, vomiting, jaundice, or a significantly increased bilirubin, ALK phos, or INR, it should also prompt discontinuation of therapy. So actually they say a CBC, creatinine, GFR, hepatic function, and I guess you would need to add an INR to that as well. And granted, it's if the patient comes in.
Yeah.
You know, our patients aren't always the most great at keeping their appointments, but like I said, the guidelines do recommend during the course of treatment, they say 4 weeks, but I would say if they show up at 6 weeks, get it at 6 weeks, that you get those labs at a minimum.
Thank you. I had one other question, if I could, please. Looking at the West Virginia Medicaid, and thank you for that, Dr. Tierney. On the prior auth form, on the second page, it looks like they want you to justify why you can't use interferon. Is there something to that? Or am I looking at an old one?
No, I think they still have it even on the new one. I don't even really talk about that, because if you go to the following pages where they're talking about the treatment options based on the based on the type, then you know, if you're following their algorithm, interferon isn't an option very often.
Yeah. Okay. Thank you.
Okay. And if it becomes an issue, if they send it back to you, you'd be amazed how many of my patients have significant depression that can't take interferon.
Well, this guy, yeah.
Yeah. But why anyone would want to use interferon in this day and age?
Yeah.
Yeah, where you will see that a lot, and where I have seen it is with Medicare patients. Apparently Medicare wants to do the interferon first. But it's amazing also how many of my Medicare patients have significant depression and can't use interferon.
Yeah.
In which case then my Harvoni or Mavyret or whatever gets approved. So that, you know, it's really awful. They have that horrible depression.
Yeah. Yep. Thank you.
And I counsel my patients about their horrible depression as well. In case they get a phone call.
Right.
I'm amazed that that still is even on the form, because as opposed to, you know, the direct acting antivirals, which give you SVR rates in excess of 95, 96, 97%, the best we ever did with interferon was about 50%. So why you would spend, and interferon isn't cheap either. So why you would spend all that money and effort and risk the toxicity for a not fabulous outcome is mysterious to me. But not only do people get depressed on interferon, people have committed suicide on interferon. It's really a drug that should be avoided.
So yeah, I just ignore it and just keep marching on.
You guys have any other questions? Anything? I think Carolyn and I spoke and decided that we're going to save the didactic for a later date, just so we can get through it all at the same time, instead of splitting it up. So you guys can carry on. We have about 10 minutes.
Could I ask a couple questions, because I need some clarification on some things that I wrote down, and either for Kaylee or Dr. Feinberg. I wrote, and this is what I heard, Medicaid will only pay one time for hepatitis C treatment in West Virginia. Is that correct? Or did I hear that wrong?
That had been their previous, one of their previous statements. But now, since they released or removed the fibrosis restrictions, they'll put, you know, they don't specify if they'll only do one lifetime treatment, but they do say if they don't have SVR12 data, they won't be offered a further course.
Okay.
So we haven't really run into that instance, particularly since they've removed this restriction on the 1st of October.
Yeah, this is Rachel from the specialty pharmacy. What I can, just to piggyback off that, what we've seen, because we do a lot of the auths here,
for these medications is that if somebody does fail treatment historically before they lifted the fibrosis requirement, if they failed treatment, and we could show that with they had an SVR12 and then it came back, or an end of treatment and it came back, that we would submit it to rational drug therapy, and they at their level would deny it, and then we would have to appeal it, and it would go to Charleston, and then they would overturn it, and actually, because we had proof, they had clearance at some point, whether it was end of treatment, and then just failed therapy at some point where the viremia came back. So we haven't had any experience yet since they lifted fibrosis restriction, because that's been so new. But I imagine it'll probably be something similar. And if they don't have that data on hand, it might be a little bit harder to prove.
And then this is for you, Matt Weimer. You had spoken to the fact that vitamin D supplementation can decrease fall risk in the elderly. Would you elaborate on that for me just a little bit, please? On actually kind of personal reasons. I have an elderly mother who's in generally very good health, but I really like to understand about this.
So I don't know. I apologize. I can't really speak to the evidence, but in the last maybe 3 to 4 months, I was reading through some materials on fall risk, and there was an evidence-based kind of point made to that end. So I will try to find it and maybe send it out somehow, either to you directly or to somebody who can get it to you. Either way, if I can find that evidence for you. I don't know the degree of, I don't know how or why it would do that. B, I don't know how much of a reduction it creates. You know, of course we like calcium and vitamin D for bone health in general, but why would it actually decrease fall risk? I'm not sure. And is it just an association, or is there a causation there? I was under the impression that there was some thought that there was somehow a causation, but again, I can't speak to the details.
Okay, that would be awesome. I have my, at the end of the slide set, you guys got a copy, I think, or else you've got it, is my email address. If you would send that to me, that would be awesome.
I'll find what I can and I'll pass it along. Absolutely.
I appreciate it. So are you, because of that, are you kind of looking at your elderly patients a little differently with their vitamin D levels? And
I mean, I feel like I chase vitamin Ds a lot and can't get people where I need to get them. It's just really challenging sometimes. But I just like to I just tell most of my patients, especially if they're osteopenic or worse, 1250 to 1500 of calcium a day and 800 to 1000 of vitamin D a day. Just even if their levels are normal, I try to get most of my patients who have some bone health issues between supplements and diet up to those daily intakes. And I think that's pretty important, especially if you have osteopenia, which is, I don't have too many patients who don't at least have osteopenia, if not osteoporosis. So.
Thank you so much. I appreciate that. I know I put you on the spot, but it really just...
No, it's okay. It'll spur me to go look for that evidence that supports that assertion. So that's good.
Great. Thank you. Dr.
Hi. Yeah, it's Dr. Tierney. Also on the vitamin D. I have also followed vitamin D for a number of years. So far, my research has shown that vitamin D is important for bones, muscles, joints, heart health, liver health, memory, mood, skin, and for men, it's a precursor for making testosterone. When you don't have enough vitamin D in your body for these processes, the vitamin D is leached out of your bones, making your bones soft. And it can lead to what we call a non-traumatic fracture. That means you're kind of like just walking down the street and maybe you just kind of stumble a little bit and you end up having a broken ankle. Based on hearing this, that it helps with falling, my thing would think it would help make your bones not soft, stronger, which would inevitably help with that type of thing. Also, the studies show that there's an inversely related proportion between low vitamin D and severity of liver disease. So if you have low vitamin D, then inversely you tend to have worse liver disease. Hang on, I'm looking at my book again. It's saying that also it's been shown that patients with lower vitamin D levels have poor responses to interferon-based therapy, which suggested an important immunomodulatory role for vitamin D in patients with chronic Hep C. So we know that vitamin D is crucially important. And what's happening is, when I was in med school, we all kind of poo-pooed these things saying, oh, we're Americans, we have really good diets, we don't need vitamin supplementation. And subsequently, all of these studies have been coming out, kind of one after another, showing how important it is to have a good vitamin D level. Dr. Feinberg and I have discussed about it. Given the number of people that we have seen with vitamin D deficiency, we are wondering if maybe how we're testing it isn't completely accurate. But, knowing that low vitamin D can cause soft bones and can cause a non-traumatic fracture, and that your body will steal the vitamin D from your bones to help do these other functions, I do strive to have all of my patients, whether they have Hep C or not, to have good vitamin D levels. And it's something I test regularly. Medicare will pay for it under an osteomalacia diagnosis code. If you need that, I'll give it to you. And also I've had Medicaid pay for it when I'm testing under that same code. So I frequently check levels in my patients.
Great, thank you.
And if you need the exact code, I'm happy to send it to you.
That'd be great.
Thank you.
Doctor, I just wanted to draw attention. Dr. Rexford had a question about vitamin D and heartburn. Dr. Tierney got back to her, but just wanted to see if anybody else had that similar experience with your patients.
You mean a complaint of heartburn from taking vitamin D? I've never heard that, even in the patients who got like the high dose 50,000 unit tablet. So
Dr. Tierney says,
I have had 3 in the last several months. Reliable, not alarmist people come back and tell me this. One of them, in fact, it was like chest pain, ordered him a stress test, and which was totally normal. And, we got to looking at what had changed before his symptoms developed, and he had started taking 5,000 units a day of vitamin D. Stopped that, the pain went away.
what about your other patients, Dr. Rexroad? What dose of vitamin D were they taking when they developed these symptoms?
Typically 5,000 units a day. Actually, all 3 of them.
Well, I wonder, because I have certainly given lots of people 50,000 units, but in terms of a daily dose, I usually use 1,000 or 2,000. I wonder if you went with a lower daily dose, whether that would not occur. I don't know.
I think some of them have, at least one of them is tolerating a lower daily dose. But I was just curious whether, I haven't had that pushback with the higher dose, and I don't know whether people aren't, with the 50,000 units once a week. So that's what made me curious about it.
I'm sure you've thought of this already, but I just have to ask, were they all on bisphosphonates as well? Because I've seen some pretty wicked stuff happen with bisphosphonates in the esophagus.
Sure. None of them.
Okay. I figured you thought about that, but I had to ask.
Dr. Tierney has her hand raised. Sorry.
There are studies that say that 5,000 a day sometimes is too much for people. And they recommend the 2,000 to 4,000 range on a daily basis. I've had a few patients who have complained of that, but they were all on the 50,000 once a week. When I did switch them and told them to pick up some over the counter, either $2,000 to $4,000, those symptoms went away. So you may just try with these patients a lower dose. And with the men, as soon as I tell them it's a precursor for making testosterone, they're on board.
I would also think about what the formulation is, like if it's a capsule, just because we do see like HCl and different things in some capsules, right, to help with absorption. So I wonder if there's something going on there as well.
And sometimes it's a question of D2 or D3.
Yeah.
Dr. Peters, if you want to ask your question real quick, and then if everybody will hold tight for announcements.
Sure. Dr. Tierney, you're going to need to prescribe me some vitamin D. So I need, I got to keep my beard right. I need to make sure. Anyway, so I just had a hepatitis B reporting question. It was kind of interesting. This came up with Jenna, who had to jump off, she and one of our new attendings at our other office had called me to help them interpret some hepatitis B results. So they got a critical lab report back that showed a surface antigen positive on hepatitis B, which indicated a new infection. But her core was negative, and her surface antibody was profoundly positive, like over 25,000 positive. And the best I could surmise was perhaps this was somebody who had previously been vaccinated, but who had been exposed to hepatitis B kind of acutely. She also had a number of STI. She had both gonorrhea and chlamydia at the time that she was evaluated. So she came back in to see another colleague of mine, is a friend of mine that I did residency with, and she called me kind of for the same thing. And we discussed that. And we actually ended up finding her previous vaccine record. And it turned out she had been vaccinated against hepatitis B correctly. So what I had her do then, and this was a week ago, was repeat her core antibody and her surface antigen, both of which are now negative. So her surface antigen, that first visit was positive and now has become negative. She's still core antibody negative. So the way I interpret that is that this is somebody who is vaccinated, is immune, was exposed, and their vaccine cleared the virus, as best I can tell. My question is, does that need reported? Because I don't know the answer to that. Like, would it be, or no, this is why we vaccinate people?
This is Kaylee, Greg. So what I'm thinking is it was just a false positive. Hep B surface.
Okay.
Yeah. Do you know how long, or can you remember how long before, but from the time that they were vaccinated to the time that surface antigen was drawn?
I think 8 years.
Okay, so it was a while.
Yeah.
Because sometimes, I mean, even if we've given the vaccine and then check the surface antigen, it can make that falsely positive. So usually if they just repeat the surface antigen in 2 months, we've actually had a number of false positive surface antigens. So and if core IgM and IgG or total antibody were both negative, surface antibodies positive, and it's vastly positive. So, I mean, she's got a great immune response. So I really think it was just a false positive.
Okay.
Right.
So there again, no, it would not. So no, it would not need reported, or.
The only thing I've actually had the health department contact me in those situations and say, hey, we had this happen. Like, can you explain? So I've still given them documentation just for their. Yeah, I would just say, I
mean, it's negative now. So I mean, I think her relative is, low. She's somebody that needs help in other facets of her life. She uses IV drugs and that sort of stuff. So she's got a lot of other things to consider. The fact that she's Hep B immune, I think, is to her benefit. So it's, but anyway.
To answer your question about reporting, labs, hospital labs and commercial plant labs automatically report all of this to the Bureau of Public Health. So I think you'd be more likely in the situation that Kaylee described, where they'll call you and say, this doesn't make sense.
I see.
If they get the two labs together, they'll probably piece it they'll probably figure it out and they'll just not ask you.
I see.
But for Hep B and Hep C and HIV, these things are automatically reported to the state.
Yeah, and she's negative for them, so it's good. But.
Thanks, Greg.
Hey, thank you guys. Appreciate it.
Thank you guys so much. Thanks everybody for joining.
Yeah, I know it's a little past time. I will let you guys know. It's on November 14th, and it will be the only one in November because the other one falls on Thanksgiving, just so everybody knows. Jen, I will do the new prior auth forms and send them out to everybody. And Matt, Matt, if you can send me the vitamin D stuff, I can get that out to everybody as well. And if anybody else needs anything, please just email me. I will email you a lot before I see you.
Thank you
all so much.
Kaylee, before you go.